This is part 2 of 3 of Cardiac Electrophysiology. In figure 4-13, which is seen on page 129, you can see the currents responsible for the ventricular action potential in the different phases of the action potential. On the bottom of the diagram, you can see the current and the ion. For example, in phase 0, you can see that sodium ions are moving into the cell. ECF stands for extracellular fluid, and ICF stands for intracellular fluid. The SA node, or the sinoatrial node, is the normal pacemaker of the heart. The configuration and ionic basis for its action potential differ in several important aspects from those in atrial, ventricular, and Purkinje fibers. This can also be seen in figure 4-12C. This is at the bottom of page 128. You can see the sinoatrial node has a different shape to its action potential than atrial, ventricular, and Purkinje fibers. The following features of the action potential on the sinoatrial node are different than those in the atrioventriculars and the Purkinje fibers. First, the SA node exhibits automaticity, that is, it can spontaneously generate action potentials without neural input. Second, it has an unstable resting membrane potential, in direct contrast to the cells in the atrial, ventricular, and Purkinje fibers. Third, it has no sustained plateau phase. The first phase is phase 0, or the upstroke. This is the upstroke of the action potential and represents the depolarization of that cell. However, notice that the upstroke is not quite as rapid or as sharp as in the other types of cardiac tissues. The ionic basis for the upstroke in the SA node differs as well. In the other myocardial cells, the upstroke is the result of an increase in sodium conductance and an inward sodium current. In the SA nodal cells, the upstroke is the result of an increase in GCA, or calcium conductance, and an inward calcium current. The same calcium current is responsible for the upstroke in the AV node as well. This inward calcium current is carried predominantly in the T-type calcium channels. T is for transient, in contrast to the L-type channels responsible for the plateau in ventricular cells. The T-type channels are not inhibited by the L-type calcium channel blockers, such as verapamil. In the sinoatrial node, phases 1 and 2 are absent. The next phase is phase 3, or repolarization. As in the other myocardial tissues, repolarization in the SA node is due to an increase in potassium conductance, or GK. Because the electrochemical driving forces on potassium are large, both the chemical and electrical driving forces favor potassium leaving the cell. There is an outward potassium current which repolarizes the membrane potential and makes the membrane potential become more negative. Phase 4 is the longest portion of the sinoatrial node action potential, and this phase accounts for the automaticity of the sinoatrial nodal cells, that is, the ability to spontaneously generate action potentials without neural input. During phase 4, the most negative value of the membrane potential, that's called the maximum diastolic potential, is approximately negative 65 millivolts, but the membrane potential does not remain at this value, as you can see. Rather, there is a slow depolarization. This is produced by the opening of sodium channels and an inward sodium current called IF. F stands for funny. This denotes that the sodium current differs from the fast sodium current responsible for the upstroke in ventricular cells. The funny current is turned on by repolarization from the preceding action potential, thus ensuring that each action potential in the sinoatrial node will be followed by another action potential. Once the funny current and slow depolarization bring the membrane potential to the threshold potential, the T-type calcium channels are open for the upstroke. The cells in the sinoatrial node are not the only myocardial cells with intrinsic automaticity. Other cells, called latent pacemakers, also have the ability for spontaneous phase 4 depolarization. These latent pacemakers include the AV nodal cells, the bundle of His, and the Purkinje fibers. Although each of these cells has the potential for automaticity, normally it is not expressed. The rule is that the pacemaker with the fastest rate of phase 4 depolarization will control the heart rate. Normally, the SA node has the fastest rate of phase 4 depolarization. Therefore, it sets the heart rate. Remember also that of all the myocardial cells, the sinoatrial node cells have the shortest action potential duration, that is, the shortest refractory period. You can see Table 4-3 shows the firing rate of sinoatrial node and the latent pacemakers in the heart. This is the top of page 131. The sinoatrial intrinsic firing rate at rest is normally 70 to 80 impulses or beats per minute. The AV node, the bundle of His, and the Purkinje fibers all have slower intrinsic firing rates. The sinoatrial node recovers faster and is ready to fire another action potential before the other cell types are ready. When the sinoatrial node drives the heart rate, the latent pacemakers are suppressed. This phenomenon is called overdrive suppression, which is explained as follows. The sinoatrial node has the fastest firing rate of all the potential pacemakers, and the impulse spreads from the sinoatrial node to the other myocardial tissues, in the sequence illustrated in figure 4-11 as we talked about previously. Although some of these tissues are potential pacemakers themselves, such as the AV node, the bundle of His, and the Purkinje fibers, as long as their firing rate is driven by the sinoatrial node, meaning instead of activating themselves, they are in turn activated by the sinoatrial node signal. Their own capacity to spontaneously depolarize is suppressed, meaning they are activated before they can self-activate. Table 4-3 is shown again here, that shows the intrinsic firing rates of the different sinoatrial node and latent pacemakers of the heart. The point to take away is that sinoatrial node has the fastest firing rate, therefore it overdrive suppresses the other possible pacemakers downstream. The latent pacemakers have an opportunity to drive the heart rate only if the sinoatrial node is suppressed or if the intrinsic firing rate of a latent pacemaker becomes faster than that of the sinoatrial node. Since the intrinsic rate of the latent pacemakers is slower than that of the sinoatrial node, the heart will beat at the slower rate if it is driven by a latent pacemaker. There are several conditions in which a latent pacemaker takes over and becomes the pacemaker of the heart, in which case it is called an ectopic pacemaker or an ectopic focus. First, if the sinoatrial node firing rate decreases, for example due to vagal nerve stimulation, or stops completely, for example because the sinoatrial node is destroyed, removed, or is suppressed by medications, then one of the latent sites will assume the role of the pacemaker in the heart, becoming a backup pacemaker. Second, or if the intrinsic rate of firing of one of the latent pacemakers should become faster than that of the sinoatrial node, then it will assume the pacemaker role. An example of this is post-cardiac surgery. Oftentimes, one of the junctional pacemakers seen in the bundle of His or in the Purkinje fibers will assume a faster heart rate than it normally would and takes over the pacemaker function of the heart. This is called a junctional tachycardia or an idiojunctional rhythm. Third, or if the conduction of action potentials from the sinoatrial node to the rest of the heart is blocked because of disease in the conducting pathways, then a latent pacemaker can appear in addition to the SA node, and this can occur at the level of the atrioventricular node, at the bundle of His, and so forth. This is called AV nodal block. This is the end of section 2 of 3 of electrophysiology.